Treatment of severe COVID-19 infection. Moderate illness includes fast breathing as per the age-defined cutoff for respiratory rate without any signs of severe pneumonia characterized by cyanosis, increased respiratory efforts in the form of grunting or severe retraction, or lethargy, somnolence, or seizures. In moderate illness, the patients need to be admitted in isolation with adequate care of feeds and fluids in order to avoid dehydration or overhydration. Antipyretics as paracetamol can be given for fever. If one suspects bacterial infection, antibiotics may be ordered. It is important to monitor the progress of these patients to severe illness during their admission. COVID pneumonia is managed like any other pneumonia where if saturation falls to less than 94%, we may need to start oxygen. In this case, if oxygen requirement is increasing, it is better to give steroids for a duration of 3 to 5 days. Remdesivir is another antiviral drug that has been found to be useful during the early course of illness. However, in those with liver dysfunction, acute or chronic kidney disease, with GFR of less than 30 who are pregnant or lactating mothers, it is better avoided. Negative pressure rooms with HEPA filter are the preferred isolation rooms for COVID-19 infection patients. In areas where negative pressure rooms are not available, single room with exhaust fan, preferably at the higher floors of building, may be used. All personnel should wear full personal protective equipments before entering isolation room. Resuscitation trolley, monitors, and all essential drugs need to be placed at the bedside. Oxygen therapy is indicated in all patients with severe acute respiratory infection and respiratory distress, hypoxia, or shock. Low flow oxygen with nasal prongs are the preferred modality of oxygen therapy initially. Surgical mask or hood may also be used to decrease aerosolization. The target saturation is 90 to 94%. In those with chronic lung diseases, lower oxygen saturation target may be used. If hypoxia persists despite nasal prong oxygen, other modalities like face mask, oxyhood, venturi mask, or non-breathing mask may be tried. We will discuss about them individually in the oxygen therapy lecture. Non-invasive respiratory support like high-flow nasal cannula or CPAP may be started in those who fail conventional oxygen therapy. High-flow nasal cannula is usually begun at a flow rate that is sufficient for patient's disease condition. The settings at beginning are based on the weight of the patient and the flow needs to be titrated to the least as tolerated by the child. In those with mild ARDS, CPAP or BiPAP can also be tried. Adequate seal is essential with due care to prevent aerosolization. All patients with moderate to severe ARDS requiring mechanical ventilation, those with shock requiring vasopressor support, worsening mental status, multi-organ dysfunction, and multi-system inflammatory syndrome of children need admission into PICU. In the early phase, a trial of HFNC, CPAP, or BiPAP may be used. Strict adherence to airborne precaution is necessary. In those who fail non-invasive support, they need to be intubated and mechanically ventilated. The most experienced trainer and a dedicated intubation team is necessary to have a successful first attempt intubation. Airway and resuscitation trolleys need to be kept ready. A good simulation with backup plan for a difficult airway prevents adverse complications. In intubation, pre-oxygenation with 100% FiO2 with a non-rebreathing mask or high-flow nasal cannula may be used. Bag and mask ventilation is better avoided. It is preferable to use cuff ET tubes with viral filters. Video laryngoscope may be used where feasible. To have healthcare provider safety, not more than 3 people are needed during intubation of a sick patient. They include intubator, one for airway assistance, and another for giving drugs and monitoring the patient. The healthcare providers need to wear full PPE with proper donning by body check. We need to dispose all soil equipments properly. Once the procedure is done, proper doffing with hand hygiene is essential. Fresh disposable circuit has to be used for every patient. Always use a viral filter that is fitted onto the circuit. Frequent suctioning or disconnection is better avoided. Closed loop suctioning is the preferred modality. During ventilation of an ARDS patient, it is preferable to ventilate with low tidal volume, individualized PEEP with higher PEEP requirement in severe ARDS, low plateau pressures of less than 28 mm of mercury, prone ventilation at least 16 to 20 hours per day, restrictive fluid management, and extracorporeal life support for refractory hypoxia where feasible. Owing to the multisystem nature of the illness, other organ systems also need to be supported. Shock needs to be resuscitated with fluid bolus and vasoactives in the presence of myocarditis or in MISI, and to tackle the hypercytokinemia storm, immunomodulators may be used. Acute kidney injury and acute liver failure may need supportive care and extracorporeal management. Several antiviral therapies have been tried in COVID illness without much benefit. Steroids are the only drugs which have been found to be having significant mortality benefit in severe COVID infection. Remdesivir may be useful in a cohort of patients who present early in whom active viral replication is occurring. Low molecular weight heparin may be used in those with moderate to severe disease with progressive elevation in D-dimer or in the presence of thrombosis or severe myocardial dysfunction. In those who fail initial management with these drug therapies, immunomodulators like tocilizumab may be tried. The goal of ICU care would be to reduce the duration of mechanical ventilation with early weaning, avoiding iatrogenic complications as ventilator-associated pneumonia, CLABSI, COTI, and pressure ulcers and ICU-related weaknesses due to several therapies such as steroids and neuromuscular blockers. A patient can be discharged after 10 days of symptom onset and clinical resolution of symptoms and a good oxygen saturation of more than 95% of oxygen for at least 3 days. This should be followed by home isolation and self-monitoring for at least 7 days. If you like these videos, please like and subscribe us and follow us for more updates.